Everyone knows that healthcare costs have gone through the roof. The money that hospitals and nursing homes spend on the bandages, needles, and complex machines to keep us alive and well is enormous, nearly $200 billion at last count. Is that money being spent wisely? Who actually keeps track? Can they be trusted? I'm Sarah Bartlett, and this is our topic today on USA Inc. Joining us today is Prakash Sethi, a university distinguished professor at Baruch College, who recently testified before the U.S. Senate on the hospital purchasing industry's business practices. Prakash, thanks for being on the show today.
My pleasure.
Let's start by having you explain how it is that hospitals actually go about their purchasing decisions.
Well, excuse me, it's very simple in many ways. Whenever you have a small group of companies or businesses, it makes sense for them to get together, combine their buying power so they could leverage it to get discounts. That's how this whole thing started. The hospitals were struggling, they did that. But over a period of time, what happens about in the early 80s, US Congress gave this buying organization, at that time they were essentially co-ops, the right to charge 3% administration fee from the suppliers.
The medical product suppliers.
Precisely. Normally it's considered kickback and it's illegal. And that's why it was given protection. The protection was meant to be in a way that since the hospitals cannot afford to pay the fee, they would do that. But what has happened, the fee income is so high at 3% that even after declaring expenses, which nobody audits, they have a lot of money left. And that money supposedly goes back to the hospitals, what we call the surplus.
These are the middlemen, in other words, that take the fee from the medical suppliers, and then whenever there is anything left over, one hopes that it gets returned to the hospitals.
Yes.
That's the theory.
That's the theory.
Okay.
In practice, what's happening is this. Because this middleman has no risk whatsoever. He has contracts for the suppliers, and he has buyers who are locked into more or less exclusive buying. Mm-hmm. Now, if you are being paid on the volume, you are very tempted, especially when there is no oversight, to maximize the volume. So, if I buy a product at a cheaper price, that means that the total amount of money that would be billed would be lower. And therefore, I would get 3% on a lower amount of money. So there's a built-in structural flaw that says the more you sell, the more you make. The supplier is perfectly happy because he's not doing any charity. He simply tacks on that to the price of the product. And so the middleman keeps getting bigger and bigger, so much so, think about it this way. The hospital purchasing right now amounts to about $165 billion a year. Think of the 3%. And now you know we are not talking about pennies here. Then, almost 80% of this purchases are controlled by GPOs.
GPOs being the general
Group Purchasing Organization, the middleman.
Okay.
2 GPOs alone control more than 60% of the market share.
Now, normally that would be considered a monopoly or an oligopoly position.
Very rich oligopoly subject to all kinds of restrictions, oversight. Actually, the law says that the term we use is C4. If you have 4 companies in an industry which control more than 50% of the market share, you cannot buy a new company, you cannot expand without first getting clearance from the Justice Department.
Because of the antitrust concerns.
Precisely,
right.
because you...
And in this case, that doesn't arise because they have this special status. I see. Okay.
Absolutely.
Now, what are the consequences of this system for the hospitals? I mean, we're in a situation, we all know that healthcare costs are soaring. Presumably, they're doing this because they think it's to their benefit.
Yes. In theory, that is correct. They could be benefiting because the hospitals individually cannot negotiate prices, and the GPOs would do it for them. But the problem is we have no system of independent monitoring to know what they are doing. Could the prices have been lower if they are? The only thing we know is whenever there's a government investigation, they find out that no, the prices are not always cheaper. And the other problem is that the GPOs also enforce, and using the enforce not lightly, on the hospitals the conditions which sometimes add to their costs.
I'm not sure I know what you mean by that.
Think of this way. The contract says that you must not use a needle or a bandage or whatever it is after 6 months. The hospital feels they're not bad, they should be used. They have to get permission from the GPO.
So they can set the standards. How about choosing the products? Can they dictate what products the hospitals use?
Absolutely. Actually, the hospitals, in many cases, the most they can buy is 5% outside the GPO contracts. If they are buying a new product, they have to get GPO's permission. Now, mind you, some GPOs are more open than others. Some hospitals are more independent than others. But most hospitals tend to become captive of inertia. They don't have that kind of expertise. And the money that GPOs have, they can create all kinds of illusions of efficiency. We are doing you a favor. In the hearings that I attended, GPOs argued that if you put more restrictions on us, hospitals would lose $2 billion in savings. How do I know? Where's the data? You do not have any information whatsoever. Plus, the investigations and also some of the lawsuits that other injured parties have filed against these companies show that in many cases, 3% is not the maximum. It's the starting point. Let me give a very interesting example. And I'm not saying that this is endemic to the entire industry, but think of this way. You have a new product, you come to me, say, this is a product, the hospitals would like it, use it, and by the way, it's generic, it's more efficient, and less expensive. Normally, you do that. What I would do is, and I know only few examples, there may be more. I would say, that's fine. Why don't you do this? Rather than signing a contract with me, sign a contract with Joe, Doe, and Company, and they will buy it from you. And
why would they do that?
Well, I happen to have equity control in Joe, Doe, and Company, so you sell that thing 5 cents a pill to Joe, Doe, and Company, and then I, as a GPO, have a contract with Joe, Doe, and Company to buy the same thing for 20 cents. And after that, I take 3% on top of that.
So they're pocketing in other ways besides the
yes.
fee. Is that widespread, or is that, in your opinion, or
well,
is that just...
Again, we don't know. We only know it when it becomes public. Somebody filed a lawsuit, or somebody said, hey, you asked me too much money, type of
now,
thing.
the GPOs will say, this is all nonsense. The hospitals don't have to use this if they don't want to. It's the clinical technicians in the hospitals that tell us what products we should buy. We don't tell them.
That is not correct.
And how do you know that?
Because we have talked to people and we have seen the contracts, what it is done. If you see some of the court testimony, essentially, and you have testimony from the doctors, saying that we had to fight with the GPO for us to use a different medication or a different supply because the GPO won't do it. GPO's argument is our contract with the supplier calls for that 90% of the supplies used by the hospitals would come from the supplier. And we lose money if we don't meet that contract, because the more you buy, the volume discounts are there. That is true. But we all keep forgetting that the 3% comes on the volume. And so you are really, until the managers of GPOs are ethically very compelled to do it differently, you give them too many incentives towards self-enrichment, towards conflict of interest. And there is no system, either within or outside, to monitor to see whether or not the numbers that are being given are indeed correct.
Now, what about the government regulators? I mean, they presumably are looked at by the Department of Justice, the FTC.
Nope.
No?
The only time they look at it when there are complaints. And they looked at it.
And I think they passed, they said
every time there's a complaint, we find out that the complaint has been well-founded. But again, remember, the problem is there. Because these outfits are privately owned companies, they don't have to give any data which a normal business would do just because it's a publicly listed company. I'm sure they file their tax returns. We are not privy to that. And they also supposedly give some information to the hospitals.
I was going to say, where are the hospitals in all this? Why are they complaining?
Well, no and yes. Some hospitals, like Kaiser Permanente, they manage their own supplies because they feel they don't need it. So you have some systems that have opted for alternatives. The other system some companies are doing is it's called integrated delivery networks, which is another way of saying we have our own co-ops. So some hospitals would create a co-op and then would say to GPO, well, we would buy from you only what we need, not what you would tell us. And so in that case, case after case, it's been shown that they look at the GPO prices and invariably they can negotiate lower prices from the same suppliers. Now, if they were not there, suppliers have no incentive to give you lower price because you can't possibly replace the GPO in terms of volume. And the last thing they want to do is antagonize the GPO. They'd be out of business. Right. The senators asked me, well, all these big guys, why don't they compete with each other? You know, this, and then the hospital would get a better deal. Now think of this way. If you and I have got the mafia example, I have got Brooklyn and you got Queens. Why would you want to risk coming into Brooklyn? Because I could also go to Queens and all it would do is help the cops find out about both of us. They keep their territory, we keep our territory. And that's why there is no competition between them.
Okay, we'll talk about some of the possible solutions. We'll be right back.
The Zicklin School of Business at Baruch College of the City University of New York is the largest and most diverse accredited business school in the United States, offering high-quality, full-time and part-time degree programs at the undergraduate, master's, and PhD levels. For information about the Zicklin School of Business, please visit our website, zicklin.baruch.cuny.edu. That's zicklin.baruch.cuny.edu.
Welcome back. I'm talking with Prakash Sethi, a University Distinguished Professor at Baruch College, who testified before the U.S. Senate on the business practices of the hospital purchasing industry. I wanted to get into the attempt that the industry has put forward to regulate itself. They've reacted to some of the complaints and the criticisms, and they've created an initiative, which you, I believe, have studied in some detail. Can you share with us both what they're attempting to propose and what you think of it?
Okay. This was my entry into this system in the sense, just as a background, as you know, I specialize in studying and creating codes of conduct, both at the company level and the industry level. And the Senate, whoever there was, felt that they wanted to understand the industry's code of conduct, and they wanted to bring somebody who was totally independent. The industry code was a response to the Senate inquiry that if you don't fix it, we will do something about it, because there was common agreement that some of the industry practices are unacceptable. So they came up with a code which has 6 principles, and essentially it says we would try to do the best we can, we would try to be very honest, we would try not to have any conflict of interest, and by the way, we would report all this to a code committee, and then they would coordinate this information, and we would also have a meeting on best industry practices that we would constantly improve. Problem solved.
And they'll publish the results of this.
The problem is this: the principles that they have are no more than simply expressions of good intent. Thou shalt be good. They are supposed to be good. What else? They don't say, what does it mean when we say we are not being good? There are no, in my own research, I have established 6 conditions which I believe, unless until you meet them, the code simply will not work. And that is, the code must be specific. It must have outcome-oriented standards, in the sense that we would keep all workers happy. What does it mean? We would pay everybody decent wages. What is decent? So, and then the claims must be independently verified. There must be an internal system that says compliance is there, and if not compliance there, somebody would be held responsible. And the independent system would verify the information, and the independent auditor would have the right to make those findings public without any prior editing by the companies. The code monitoring system should be quite independent. You have something very different here. The same people, 9 GPOs signed this initiative, including the 2 biggest ones. The steering committee of the principals consists of the same CEOs whose performance they are going to be measured.
So they're monitoring themselves.
Precisely. Now tell me, please, why is this system worthy of trust? Here are the people who were forced to create a code to monitor the industry's performance. It simply says, like Alice in Wonderland, words mean what I say they mean. And then they want you to accept the words, not according to what you see, but what they say they mean. It doesn't simply work. And the coordinator is also an employee
of the industry.
Because he is a consultant, he's part of the law firm. And so he's paid by the people he's being asked to. Excellent. And plus, remember, he's asked a coordinator of the information. He does not create information. He does not check the information. He simply coordinates it, and then they publish it. Now, talk about the best industry practices. And I'm very outspoken on that issue. In the absence of outside input, best industry practices is an oxymoron. You and I are the 2 big 800-pound gorillas. We have practices which we are very comfortable with. If it's machines, we know what we are doing. If operating systems, we know we are doing. Let's say you have a better idea in some area and I have a better idea in one area. Why would you impose your idea on me? Because then you would also worry about my idea being imposed on you. What would happen? Your cost would go up and my cost would go up. Why should we do it? The world doesn't know what's the best industry practice. So we decide what's the best industry practice, and we say, voila, we have best industry practices. There is no outside voice to say, what makes it best?
Now, have you told this to the senators?
Of course I did.
And what was their response? Do they understand the points that you're making?
Well, I'm sure they do. I'm sure they do. But, I do not know how the Senate works. And there are different pressures on different senators. But I did make it clear that unless until the code is independently monitored. It cannot be depended upon to make any improvements. And even if it were independently monitored, if it doesn't have any standards, what is it you're going to monitor?
Now, the industry would say you need to give us a chance to let this work. We
Why?
just put it into place in
Why should
January.
I give you a chance?
Well,
what is it there that gives me comfort that you would actually do something? You know the things that were done by the industry that were considered unethical, self-infringement, conflict of interest, and now you come up with the code says, we would not have any conflict of interest. Why should I trust you?
What would you do to change all of this?
Well, the best thing would be simply to take away this so-called safe harbor, because safe harbor doesn't save anything.
Let's make sure that we're clear on what that this is the protection that the industry was given many years ago.
That's right.
To charge
Plus,
this fee.
That you are entitled to charge 3% administrative fee. So everything your hospitals buy, you get 3%.
So in other industries without that safe harbor, that would be perceived as almost like a kickback.
It is a kickback.
It is a kickback. But in this industry, because they've been afforded this special status, it's not. So you'd get rid of that.
Yeah. What happened? Well, that would be the best thing to do.
Right.
Because the assumption that if we did that, hospitals would go broke because they would lose all that money, again, with all due respect, is an oxymoron. Which supplier, if I am selling you $100 million worth of products and I'm giving 3% administrative fee on it, which supplier do you think would do it out of charity? That is cost of doing business, and it is included in the price of the product.
So if they sold it directly to the hospital and got rid of the middleman, you
The
think
hospitals would get it, essentially. And I'm sure if you talk with the suppliers and they knew the option is either A or B, it doesn't matter to them. Right now, they would rather not do it because hospitals do not have mechanisms to use it, and the middleman is very important to them. But suppose we did this. Right now, we have this problem, and I'm going to use a very simple example. Think of New York City, and you have a department that collects money from parking meters. Think of it as the GPOs. They go around all their people, they get all the coins, the quarters, and everything else. They come home, and they know that they've got $2 million worth of things. They say, okay, folks, I think we need $1 million to run our show. So you keep that $1 million. Now we got $1 million left. What we do? I think we should give only $50,000 to the cops, police department, because they are after my neck, you know. And maybe I should give less to the garbage collectors because they keep moving the cars. That is what GPOs are doing. A, they decide for themselves how much they would use for operating expenses. B, then they decide how each hospital would share. They say, this is your share. And don't worry about it, we keep very good track of it. But suppose I did this. I asked the hospitals, because majority of them are not-for-profit hospitals, set up a trust committee. Not big organization, just a trust committee, hospital members elected, and with 2 or 3 outside experts. The safe harbor is transferred to this committee and not the GPOs. They get the 3%. Now, then GPOs become no more than any outsourcing organization, like Prof system or electronic data system. I would say, okay, 5 GPOs, I want you to bid for my services. How much will you charge?
and get some competition between the GPOs.
Yeah. But the point is,
and put
then
the control.
I decide whether your service is worth the money you're asking for, rather than you deciding how much my service is worth, just like the CEOs of some of these companies. They decide it, and that's it. If you see today's newspapers, the hospitals and the patients are going broke. And who's making money? The GPOs and the healthcare insurance companies. The recent example of I don't remember his name.
United Healthcare?
Yes, absolutely, $1 billion. Now, if he can afford $1 billion, of course, it's coming out of the money that provides the services. Why is it their service cost is so high? Why shouldn't that million go down to billion to, let's say, 50 million? Should be enough for him to live on. and put that money back in terms of increase
Patient care.
patient care or increase prices paid to the hospitals or lower deductible, millions of things.
Yeah, well, that's the way to start working on the healthcare problem. I've been fortunate to talk with Prakash Sethi, a university distinguished professor at Baruch College. Thank you, Prakash, for being on
My
the show.
pleasure.
We'll be right back.
Some people think of New York as the world's second home. The City University of New York, with students coming from 90 countries and speaking more than 155 languages, is the world's first university. Find us on the web at cuny.edu or call us at 1-800-CUNY-YES.
Logic would tell you that giving business people the authority to make billion-dollar decisions about other people's health care without regulatory oversight is a bad idea, especially when those same people stand to benefit personally from those business decisions. Yet that is the situation that prevails in hospital purchasing. There's an inherent conflict of interest. The industry acknowledges problems in its past and points with pride to its new code of ethics. It begs policymakers to give its new self-imposed guidelines a chance. That might be reasonable if the code came with teeth, but it assumes that an industry with a history of abuses is now capable of policing itself and offers no consequences for those who go astray. Regulation is not necessarily the answer either, especially given our strapped federal resources. It's the underlying system of financial incentives in hospital purchasing that needs to be changed. Until that occurs, everything else is window dressing. I'm Sarah Bartlett, and this is USA Inc.